everyone. I'm Nahla Hamouda from the College of Pharmacy at Lincoln University. For you, as a pharmacist, before prescribing any drug to a female patient, you have to ask her two important questions. Are you pregnant or expecting pregnancy? Or are you a lactating mother? I know this question is a little bit embarrassing and you may be shy to ask, but you are from the medical team. You care about the safety of your patient. Please don't be shy and ask your female patient these two questions. Are you pregnant or are you lactating? Okay? Please don't forget. So, what is pharmacotherapy in pregnancy? First, what is pregnancy? Pregnancy, it is a time from fertilization or fusion of the sperm and ova, which we call conception, till the fetus is born. Simply, we all know that the total duration of pregnancy is 9 months. But in medicine, we calculate it in weeks. We say full duration is 40 weeks and we call this baby a full-term baby. Means he is about 40 weeks of age. The 9 months of pregnancy in medicine, we divide it into 3 trimesters. Trimester means 3 months. So 3 trimesters means 9 months. The first trimester, which is the first 3 months of pregnancy, the second trimester, which is the second 3 months of pregnancy, and the third trimester, which is the third month of pregnancy. To make it more clear, I would like to show you the diagram. So, as we said, the full-term baby is about 40 weeks. And we have a cut point here, the 38 weeks. From 38 to 40 weeks, we say it's a full-term baby. But before 38 weeks, we call the baby preterm. Pre means before. Term means the full development, or before the 30 weeks of gestation. Here, let's divide the total duration into 3 trimesters. The first till week number 12, the second trimester from till week number 24, and the third trimester till week number 38. After 38, it's a full term. Before 38, it's a preterm. Why it's important to know this information? Because giving the drug to the mother during these different trimesters has different effects. It's important for us as a pharmacologist and pharmacist to know the difference. Okay, so let's have a closer look to the pregnancy. In pregnancy, a very famous organ developed called the placenta. I think you all heard about the placenta. This is the placenta. Simply, this organ is the site of connection between the mother and the baby. It develops in the uterus during pregnancy. What is the function of placenta? Bring oxygen and nutrients from the mother across to the baby. And the baby is growing up. So there is waste products and carbon dioxide. So the placenta removed from the baby and give it to the mother. There is an exchange of oxygen and nutrients through the placenta. The placenta is like a barrier between the mother blood and the fetus blood. But this barrier, as you can see here, is not so perfect barrier. It means some drugs and chemicals given to the mother can easily pass through the placenta and reach the baby and can lead to severe side effects. That is why it's important to understand about pharmacotherapy in pregnancy. First, let's describe what happens in the pharmacokinetics in pregnancy. This is the normal physiological changes. And I want to remind you about the four main categories of pharmacokinetics: the absorption, the metabolism, the distribution, and the excretion. What happens? What is the effect of pregnancy on these four parameters? First, drug absorption. There is a slowing down of the gastric motility and drug absorption. And always pregnant mothers, they have nausea and vomiting. Sometimes they cannot even drink a cup of water because of the severe nausea. Whenever they drink or eat, automatically they vomit. This condition is very common, and so if the mother has to take oral drugs, she cannot follow up on the drug compliance, and the disease can be worse. Next, the drug metabolism. There is an increase in the hepatic metabolism of drugs, especially the lipid soluble. It means the drug breakdown in the mother is very high. Next is the drug distribution. There is an increase in the total blood volume because the mother has fluid retention, so the volume of distribution will be larger. What does this mean? Normally, in our body, we have about 6 liters of water. This is the total volume of distribution. In the pregnant mother, there is a fluid retention. It means the amount of fluid in her body is increased. So instead of 6 liters, for example, she has up to maybe 11 or 12 liters. So imagine the same amount of drug which should be distributed in 6 liters. Now it should be distributed in 12 liters. So automatically the drug concentration in this large volume of distribution will be low. Also, there is a decrease in the protein binding with increase in the passage of drugs through the placenta. Usually, about 90% of any drug in the blood is carried in a protein carrier, and this protein is tightly binding to the drug. In pregnancy, there is a decrease in protein binding. It means the drug is no longer carried on the protein, so it's free in the blood and can easily go to the placenta and cross to the fetus. Last is the drug excretion. The excretion through the kidney is increased with high drug elimination rate. So more drug is washed out from the body due to increased excretion. Have you ever thought about why these changes happen in pregnancy? This is because of the progesterone level. Progesterone hormone is the hormone of pregnancy, which is the highest level during pregnancy. So the progesterone hormone has all these effects on the pharmacokinetics. So these effects cannot be prevented. So, what are the factors affecting the placental drug transfer? It means when we expect this drug to cross the placenta at high rate and when we expect the drug not to cross the placenta. It depends on several factors. First, the physiochemical properties of the drug. For example, drugs with high molecular weight, they cannot pass the placenta like drugs with small molecular weight. Next, the rate at which drug crosses the placenta and the amount of drug reaching the fetus. It depends on the dose of the drug. Is it a large dose or a small dose? The duration of exposure to the drug. For example, is the mother taking this drug for 1 week, 1 month, or for 3 months? Of course, when the time or duration increases, the amount of drug is expected to increase crossing the placenta. Also, the distribution characteristics in different fetal tissues. It means we know that brain tissue or nervous tissue can easily absorb or attract the different drugs. So the drug concentration in the brain of the baby will be higher than the drug concentration, for example, in the liver of the baby. Also, the stage of placental and fetal development at the time of exposure to the drug. It means the mother took the medicine in the first trimester, the second trimester, or the third trimester, which is more dangerous. And the effect of drugs used in combination. Some drugs, if they are used together, they can affect the absorption, metabolism, excretion, and distribution of each other. So if the mother is taking multiple drugs, then we can think about the amount of drugs reaching the baby through the placenta. Why it's important to know these factors? Because some drugs or some agents are called teratogenic agents. These agents we are going to talk about in the next video, and these agents are the main cause of damage or defects in the newborn because of ingestion of drugs during pregnancy. Okay, thank you, and follow up in the next video.